Hi, my name is Amber Ramirez, and today we'll be going over different range of motion assessments. First, we'll be starting with a bilateral hip and knee flexion, going into two different variations of modified Thomas test for rectus femoris and for the Iliopsoas muscle. Then we'll be going into an active straight leg raise, followed by an active knee extension. Then finally, we'll be going into the dorsiflexion assessment, and the client that has been kind enough to participate for today is my brother, Ray Ramirez. This is Ray, and we're going to go straight into all of the assessments. Thank you. Now we'll be covering bilateral hip and knee flexion assessment, which is a foundation test that evaluates deep hip flexion and pelvic stability, focusing primarily on the glute max. This muscle is essential for hip extension and maintaining pelvic control during activities like sprinting and squatting. We'll start by sitting the client near the edge of the table with their tailbone just off, then have them roll back into that supine position without sliding up. Now, here you see me checking to make sure that their pelvis is in that neutral position before the client even attempts to pull their knees to their chest and hold that position. Since my client's setup was good, I then cued him to pull both knees to his chest line and hold that position while I stop to take some quick pictures for his written document where he'll be able to dissect all of the information and results from his assessments. After taking these pictures, we do aim for approximately 120 degrees of hip flexion with the femur lines up with chest level. Maintaining a neutral pelvis throughout this assessment is crucial. We don't want no excessive arching or tucking, as poor pelvic position can produce false positives, especially for the upcoming modified Thomas test. Pelvic tilt can falsely increase apparent hip flexion, messing up with the results and masking actual muscle mobility. We measure both hip and knee flexion equal with an inclinometer placed parallel to femur and the tibia. We hope that most athletes are able to reach 120 degrees with good pelvic control. Early pelvic tilt or limited range indicates limitation in the glute maximus or pelvic stability, which can deeply impact their step depth, squat depth, and running mechanics. Next is the modified Thomas test with a focus on assessing the rectus femoris muscle. The goal of the test is to determine if the rectus femoris is limiting hip extension when the knee is flexed. The muscle is a key hip flexor that crosses both the hip and knee, so this test places it under maximum stretch across both joints. This test specifically targets the rectus femoris, a biarticular quadricep muscle that flexes the hip and extends the knee. First, the client lies supine at the edge of the table with their tailbone just off so that the quad can hang freely. This is important to allow an accurate measurement of hip extension. Next, I cue the client to pull both knees towards their chest so that the hip and knees are deeply flexed. I hold the quadrilateral knee down to stabilize the pelvis and prevent compensations. Then for the test leg, I cue the client to have a knee flexed and have him slowly lower or drop his leg down off the edge of the table in a controlled manner. They lower until they feeling a stretching sensation or discomfort, indicating the limit of their hip extension range with the knee flex. At this point, I will then place the inclinometer parallel to the femur to measure the hip extension angle. Ideally, we expect a value between 0 to negative 15 degrees. Values any higher than that indicate limited rectus femoris length. If you observe poor range on both sides, it suggests that the client has reduced mobility in the rectus femoris muscle bilaterally. This can impact hip extension during activities like sprinting and may actually increase injury risk if not addressed. Now for the second variation of the modified Thomas test. This assesses the Iliopsoas muscle. This version is designed to evaluate the mobility of the Iliopsoas, which is a monoarticular hip flexor primarily responsible for the hip flexion. The Iliopsoas crosses only the hip joint, so unlike the rectus femoris test, this variation assesses hip flexor length without the knee being flexed. Similar to before, the client lies supine with their tailbone just off the table edge to allow free movement of the legs. I then cue the client to pull both knees towards the chest, holding the quadrilateral leg stable. For the test leg, I cue to keep the knees fully extended and have the client slowly lower the test leg off the table in a controlled manner until they have reached a point of stretch or discomfort. At this point, I place the inclinometer parallel to the femur to measure hip extension angle. We expect a range from approximately 0 to negative 15 degrees. Values exceeding this range suggest mobility issues in the Iliopsoas muscle, limiting hip extension. Next, we have the active straight leg raise, a test that assesses hamstring mobility and lumbopelvic control. This test evaluates the ability to actively flex the hip with the knee extended, mainly targeting hamstring length and neuromuscular control. Have the client lie supine and flat on the table. Then for the non-test leg, will be held down firmly to stabilize the pelvis. I will then cue the client to keep the test leg straight and slowly lift it upward as high as possible without bending the knee or tilting the pelvis. At the point of maximum leg raise or when the client feels tension, we're going to place the inclinometer parallel to the tibia to measure hip flexion ankle. A common qualitative measure is the position of the ankle. If the foot remains below mid-thigh, mobility may be limited. If it reaches over the mid-thigh or higher, that's typically a good result. Limited range or pelvic compensation during the lift may indicate hamstring limitation or pelvic instability. Next, we have the active knee extension test, another valuable assessment of hamstring mobility, especially focusing on that distal hamstring length. The client will be in a supine position with the non-test leg held down firmly on the table by a helper. Once that is secured, the test leg, meaning the hip, will be start flexed at 90 degrees. When the client's setup looks good, I will then cue him to actively straighten the knee as much as possible without moving his hip or his pelvis. When the client cannot reach maximum knee extension, I will use an inclinometer placed along the tibia to measure that ankle. Normal knee extension is usually close to 0 degrees or slightly bent at around 10 to 15 degrees of flexion. Larger angles, meaning less extension, suggest that there is a lack of mobility in that distal hamstring. Next, we have the standing ankle dorsiflexion screen, an assessment used to measure functional ankle mobility and the extensibility of the soleus muscle. The client will stand in a staggered stance with one foot directly behind the other. I will cue the client to flex the back knee, which forces the ankle into that dorsiflexion position while keeping the heel firmly on the ground. Once the client reaches their maximum range, I will place the inclinometer parallel to the tibia to measure the angle. Limited dorsiflexion will significantly impact sports actions like deep squatting, sprinting, and jumping. Last assessment of the day, we have the weight-bearing lunge test with knee extended. This test evaluates closed-chain ankle dorsiflexion with the knee fully extended, which isolates the gastrocnemius muscle. The goal is to identify any mobility limitations, checking for side-to-side differences, and understanding how these restrictions may affect landing mechanics, acceleration, deceleration, and change of direction performance. To perform this assessment, I'll have the participant place both hands on the wall for support. From here, they'll step the test leg back while keeping the knee completely straight. I'll line the foot up parallel to the tape line on the floor, making sure that the second toe and heel stick directly over the line. This helps keep the ankle in neutral position so that the foot doesn't roll inward, giving us a false increase in dorsiflexion. Once the setup is correct, I'll cue the participant to lean forward until they feel a strong stretch in the back lower leg. Throughout the movement, the heel must stay down and the knee must stay straight, because bending the knee would shift the stretch from gastrocnemius into that soleus muscle, which is not what we're testing here. Once they reach their maximum stretch, I'll take my inclinometer and record the final dorsiflexion angle.